Pulmonary Disorders, Chapter 8, by Harvey Olivio. COPD, chronic obstructive pulmonary disease. It's comprised of emphysema, chronic bronchitis, and small airway disease. This chapter consists of information on asthma, cystic fibrosis, acute bronchitis, influenza, pneumonia, tuberculosis, pneumothorax, pulmonary embolism, foreign body aspiration, upper respiratory infection, sinusitis, and pharyngitis. Chronic bronchitis. The excessive bronchial mucus secretions resulting in a daily productive cough for at least 3 successive months and at least 2 consecutive years in a patient for which all other causes of chronic cough have been excluded. Cigarette smoke is the most common irritant that paralyzes the mucociliary activity, resulting in increased mucus in the airways and instigating inflammatory cell response in the pulmonary parenchyma. Emphysema. Alveolar wall destruction with irregular permanent airspace enlargement distal to the terminal bronchiole without evidence of fibrosis. 2 most common causes of emphysema are cigarette smoking and genetics, specifically alpha-1 antitrypsin deficiency. Other inhaled pollutants are also noted. There are 2 types of emphysema: centrilobular emphysema, which involves the proximal portion of the sinus and affects the respiratory bronchioles without involving the alveoli. Panacenar emphysema involves the entire sinus, alveolar ducts, and alveoli, which can result in alveolar air trapping. Centrilobular is more common and is more associated with smoking. It's also found in the upper lobes. Panacenar emphysema can be associated with cigarette smoking, but is more often associated with alpha-1 antitrypsin deficiency. It is found in the lower lobes in the elderly population. Diagnosis of COPD should be proven through evaluation of pulmonary function with spirometry, the gold standard in diagnosis of COPD. It evaluates forced vital capacity and FEV1. The ratio of FEV1, FVC, can be calculated, and these 3 measurements are used to evaluate a patient's disease when compared to reference data. A chest X-ray may reveal characteristics, signs of hyperlucency, bullous disease, flattened diaphragms, and increased diameter, but it is rarely diagnostic. Blood work may include evaluation of hematocrit and ABG. An elevated hematocrit may indicate polycythemia, an overproduction of red blood cells. Per gold standard, an ABG should be included in workup of any patient with FEV1 less than 50% predicted. Testing for alpha-1 antitrypsin deficiency should be considered in all patients with COPD who present prior to 45 years old. Prevention is the key. Relieving the patient's symptoms, preventing disease progression, improving exercise tolerance, improving health status, preventing and treating complications, preventing and treating exacerbation, and decreased mortality. Patient education for COPD and its progression, smoking cessation, symptom control, therapy, treatment, goals and expectations, and managing exacerbations, plus end-of-life issues. Long-acting bronchodilators are considered superior in comparison to intermittently used short-acting bronchodilators because they provide a convenient and predictable dosing schedule and are effective in increasing the time between exacerbations and decreasing the need for rescue medications. Anticholinergics have a slower onset of action than short-acting, but they last longer. Combination therapy with beta-2 agonists, anticholinergic, and theophylline is available and has been found to provide enhanced bronchodilation and clinical improvement. Asthma is the airway hyperresponsiveness, inflammation, and varying degrees of reversible and non-reversible airflow obstruction, depending on the chronicity of the disease. Bronchoconstriction results from a contraction of the bronchial smooth muscles to irritants and allergens, resulting in an inflammatory response. The presence of persistent inflammation of the bronchioles leads to airway edema, characterized by augmented smooth muscles, excessive mucus production, and small airway mucus plugging. Psychological factors such as emotional stress can often make an attack worse through bronchoconstriction, mediated through the parasympathetic nervous system. All beta blockers can induce bronchoconstriction, worsening existing asthma. The use of this medication in asthmatics may lead to death and should be avoided. Aspirin and all non-selective COX inhibitors should be avoided in asthmatics because they can induce wheezing. Management involves promoting normal functioning of the individual and prevention of future attacks. Management is twofold. One is pharmacologic therapy, and two is non-pharmacologic therapy. Cystic fibrosis, an autosomal recessive disease that affects the lungs, sweat glands, pancreas, gastric intestinal tract, liver, gallbladder, and reproductive organs. The disease is a consequence of gene mutations, most common in Caucasians. Respiratory failure is the most recognized cause of mortality in patients with CS and typically occurs secondary to an infectious process. Diagnosed through sweat tests. Management through inhalation of hypertonic saline and bronchodilator therapy. Management also includes nutrition, pulmonary hygiene, CPT, postural drainage, vaccinations, and antibiotics. Acute bronchitis, inflammation of the large airways of the lungs. Viruses are the leading cause of bronchitis. Viruses responsible are influenza A and B, parainfluenza, RSV, coronavirus, adenovirus, rhinovirus, and human metapneumovirus. Management includes rest, fluid intake, humidified air, non-steroidal anti-inflammatory agents, expectorants, cough suppressants, and bronchodilators may be helpful. Influenza is acute respiratory illness that affects both the upper and lower respiratory tract. It is caused by one of three influenza viruses, A, B, or C. Outbreaks are more common with influenza A. Transmission occurs through small aerosolized respiratory droplets and less commonly from direct contact with an infected individual. Signs and symptoms include high fever, cough, sore throat, runny nose. Prevention of infection is through vaccination and basic hygiene principles. Pneumonia, an acute infection of the lower respiratory tract that causes an inflammatory process of the lung parenchyma involving interstitial tissues, distal airways, and ascending, often divided into two groups, CAP, community-acquired, and HCAP, healthcare-associated pneumonia. HCAP includes hospital-acquired pneumonia, ventilator-associated pneumonia, and pneumonias that occur in other healthcare settings. Pneumonia may present acutely or insidiously, depending on the infected organism. The diagnosis of pneumonia is suspected after a thorough history and physical examination have been obtained. Chest X-ray confirms the presence of pneumonia. Bacterial pneumonia are treated with antibiotics and supportive therapy. Viral pneumonias, unless complicated by bacterial, will not respond to antibiotics. However, some antiviral agents have been very effective. Tuberculosis, an infection caused by the Mycobacterium tuberculosis complex, of which Mycobacterium tuberculosis, a rod-shaped bacillus, is the most common pathogen. Signs and symptoms: blood-tinged sputum, fever, night sweats, weight loss, fatigue. Diagnosis is with an X-ray and Nordic view. PPD skin tests will also determine who is infected. Management by stopping the spread of infection and decreasing mortality by curing disease with proper treatment. Recommended drugs are isoniazid, rifampin, pyrazimide, and ethambutol. Pneumothorax, air within the pleural space from partial or complete lung collapse, which can result spontaneously or secondary to a traumatic event. Complaint of acute onset of shortness of breath and sharp chest pain. Patients may appear cyanotic, tachycardic, have a tracheal shift, asymmetric chest movement, jugular venous distension, and altered mental status. Diagnosis made with chest x-ray. Treatment may be chest tubes, thoracotomy, supplemental oxygen, large bore needles, 14 to 16 gauge, placed in the second intercostal space. Pulmonary embolism can be described as a partial or complete blockage of a pulmonary artery with an endogenous substance that can lead to respiratory or hemodynamic compromise. The most common cause include air, fat, amniotic fluid, tissue, and foreign bodies. The most common symptom is dyspnea, a sharp pleuritic chest pain. Other signs include cough, hemoptysis, tachycardia, low-grade fever, crackles, anxiety, or restlessness. Chest CT with IV contrast is most often used for the diagnosis of PE. PE is life-threatening. Treatment and prevention are part of management. Treatment with supplemental oxygen, fluids, anticoagulation, and inferior vena cava filter. Foreign body aspiration most likely occurs in infants and toddler populations. 73% occurs before the age of 3 years. A risk exists with the elderly who have difficulty swallowing. In the case of complete obstruction, symptoms may progress to the victim being unable to speak or cough. The Heimlich maneuver, abdominal thrust, or back blows should be performed immediately in an attempt to expel the foreign body. Treatment requires immediate removal upon discovery. Upper respiratory infections. Upper respiratory infections are highly communicable illnesses. Nearly 75% are due to viruses, with rhinovirus being the most common pathogen. Other viruses include influenza, parainfluenza, coronavirus, adenovirus, RSV, and many others. The clinical picture is difficult to differentiate from those due to bacterial infection, which has resulted in overtreatment of viral infections with antibiotics, contributing to resistance. Signs and symptoms are sore throat, nasal congestion, cough, fever, conjunctivitis, and hoarseness. Management should include fluids, rest, decongestants, non-steroidal anti-inflammatory medication, acetaminophen, and lozenges for cough. Sinusitis, acute chronic inflammatory condition of the mucous membranes of any portion of the four paired paranasal sinuses. Sinusitis may be acute, less than 4 weeks, or chronic, more than 12 weeks, and it may result from both infections and no infection causes. Chronic sinusitis is most often bacterial or fungal. Treatment varies with severity and symptoms. Application of moist heat for relief of pain to the sinuses and nasal area. A cool mist ultrasonic humidifier to thin secretions, and analgesics such as acetaminophen to relieve minor pain and discomfort. Pharyngitis, inflammation of the pharynx that is caused by a variety of pathogens. Most common include viruses and bacteria. Viral pharyngitis is caused by the same viruses responsible for respiratory infections. General clinical findings include a mild scratchy sore throat, pain during swallowing, occasional fever and headache. Management includes intramuscular injection of benzathine, penicillin, oral penicillin, or oral erythromycin in penicillin allergic patients. This concludes my presentation. Thank you and have a great day.